All right, so now I'm going to record this just in case. So we're going to, Brandy, would you kill the lights, please? If we see people heading into the library, we'll leave. Oops, looks like Katie's going into the library. So
Yeah, she wants to start.
let's do that. Let's just go ahead and do that, and we'll come back and do this, and I will pause the urinary tract diseases. We're going to be, this is a partial list that we'll be dealing with. Urinary tract disorders affect both the urinary system and, in men, their genital system, because they're intimately connected together. Infections, stones, and cancer. Stones are basically rocks that are conglomerated minerals that we carry and get generated under certain circumstances. Whenever you see the word lith, L-I-T-H, or the syllable lith in a medical terminology, it's referring to a stone of some sort. And a lot of these problems are age-related. Maddie? No, that's different. The stones are different. Cancer, when we're looking at, let's see, let's go back up. Infections, stones, and cancer, 3 different classes of conditions that a person can have.
Okay, so
Okay?
I marked them together.
Yeah, you do, yeah.
I was like, that stones through the body.
Sometimes they don't. Sometimes they're,
you surgically get them.
Yeah.
Because they're blocking things that.
yep, that's true, and they're painful. Urinary tract infections, pyuria, pyo comes from a Greek word that refers to infection. Urea obviously refers to the urinary system, so we tear that word apart. They are so common, it's unbelievable. Urinary tract infections are 40% of all hospital-acquired infections, and hundreds of thousands of people a year die from them. We'll talk about those later on in the class to more extent. Normally speaking, urine is sterile. In fact, some of the early explorers in places like Australia and Africa, when they were in areas, desert areas where there was no water, they drank their own urine, perfectly safe. Didn't taste very good. There should be no microorganisms in your urine, so they should be sterile for everyone. When we get into other areas of the body where the microorganisms live, then that, what we call the microbiome, does vary from individual to individual. It varies less in individuals who share a common environment, like a family. Let's see, okay. UTIs are very common. The symptoms are pain on urination, often frequent urination, other pains that you can have. Kidney infections are an extreme form of urinary tract infection where the bacteria have moved up the ureters and into the kidney. And that is really associated with a lot of back pain. You can have bloody urine, you can have cloudy, foul-smelling urine, or the urine can be clear, or there can be no blood at all. Come in, Sammy.
Oh, I kind of feel how.
Okay.
Sorry, we breaked early.
Okay. No problem. You'll only be a minute. Let's see if this is good. There's good volume here. So we also have cystitis, which is a bladder infection, urethritis, what we call pyelonephritis. That's a kidney infection. Usually these are infections that have migrated from the bladder, but not always. You can have infections in kidneys when you have general systemic infections like septicemia. And it has all of the usual pain, fever, chills, along with the potential for kidney damage. And kidney damage is really dangerous. There are several things here in this this PowerPoint that mention where these things come from. UTIs are, I said that 40% of hospital-acquired infections are urinary tract infections. They're almost, the vast majority of those are catheter-related. And we'll talk about catheter-acquired UTIs later on in the class. Women can be exposed to UTIs with sexual activity because bacteria get transferred from skin to the area around the entrance to her urethra. Diabetes is another source of these things because of other problems with the immune system and diabetes. How do we diagnose these things? Theoretically, we should culture any infection. We don't. We will make guesses as to what's causing the UTI. Most of the UTIs are E. coli because these things get transferred during the process of cleaning up after a bowel movement. These things can get transferred into the urinary tract at that time. Staph aureus, simply because we all carry Staph aureus on our skin, always. The other sources here are much rarer. If you look at this, somewhere between 90 and 95% of infections come from E. coli and Staph aureus. So the rest of them are relatively minor, but they also, Klebsiella, Proteus, and Enterobacter will come either out of the digestive tract or off the skin. Kidney stones, liths, lots of names for them. They form in the kidneys, but migrate. They move around. What happens is they get made of minerals that concentrated urine contains, and move. They exit. They also contain uric acid and other potentials. Calcium is another major component of these kidney stones. They're generally pretty small, and we probably have a lot more of them than most people know. But if they get pretty much bigger, more than about 2 millimeters in size, then they can start causing problems as they move out of the ureter or move out of the kidney into the ureter. You can feel pain in a wide variety of areas. This makes them a little bit hard to diagnose, unless, of course, you have a history of kidney stones. And a lot of people that have kidney stones have recurring kidney stones. It can be very, very painful. Women will say that it's worse than childbirth. Yeah.
No,
That's interesting. I think that I've heard people talk about gallstones. I've seen there's been other things that have that also can set off that. But yeah, these things, none of these things are nice. And they can form in a wide variety of locations. And we can deposit minerals in a wide variety. Gout is just a deposit of uric acid in joints. And basically, it's like pouring sand into your joints. Yeah, yeah. Well, well, then he needs to put up with that thing. Men seem to get them more than women. Treatment is pain medications, the entire spectrum of pain medication. Lots of water to try and dissolve them. Surgery is used. We can use ultrasound. Lithotripsy is using ultrasound to use sound waves to break up the stone. And then put some sort of a drain in. Uteroscopy is basically running a tube in there and then using a laser to kill off the stone and pick up the pieces. And then we can actually cut back into the back itself to actually remove these. A common problem with the genitourinary system in men, obviously, is benign prostatic hyperplasia, which basically just means an enlarged prostate gland. BPH is not cancer. BPH doesn't lead necessarily to cancer, but this is a gland that surrounds the urethra, and as it enlarges, it constricts the urethra and constricts blood flow. It's not particularly painful until it really constricts the flow and makes urination painful, but it's very common. It occurs mainly in men above the age of 60. I've seen statistics that talk about 60 or 70% of men, elderly men, will have BPH. So, Maddie, we've moved on, but I'm recording this. You can fast forward and pick up where you missed, okay? So, Sammy was able to help you. Good. And really, it's not particularly painful, but the real symptom of BPH is frequent urination and small amounts of urination, because the bladder, only so much is going to flow out of the bladder, and difficulty. It can get to the point where we need to do something about it. Mild BPH can just be ignored. And in fact, I had an oncologist friend of mine one time tell me that every man is going to have an enlarged prostate if he has a prostate still, right? So it's really there. So the treatments that we need depend on how severe this is, how uncomfortable it is for the man, and that really revolves around the size, because the size dictates just how much pressure it's putting on the urethra, and maybe other health conditions. Age. There are some treatments that are not suitable for patients of certain ages, and patient preference. I recently accompanied a friend of ours who was just scared to death that his enlarged prostate was cancer. He was convinced. And I said, chances are 99% no. But he was worried. So I accompanied him to his urologist. And just sat and listened, basically. And very quickly, the urologist said, you have an enlarged prostate. It's not cancer, it's just an enlarged prostate. And we talked about what he was doing. He'd been taking one of the drugs to treat this, and it wasn't working. He'd been taking it for all of 2 weeks, and it wasn't working. And when he said that, I said, well, I wish you'd told me that. I could have answered this question. And the urologist said, it takes 6 months to show an effect. All of a sudden, his worries are gone because it wasn't the big C, right? But and he's my age, maybe a couple of years older. So he was concerned, but he did not want to have surgical treatments. And there are several surgical treatments. We'll get that in a bit. There are some medications that men can take. One of them, Cialis, has another use as well. And that's the reason that it works, because the expansion of the blood vessels in the area around the urethra, which also happens to be the penis, then expands the urethra. So that's why that works. We use drugs that we call them 5-alpha reductase inhibitors. Proscar is the prototypical drug to shrink the prostate by interfering with the hormonal flow, or alpha blockers like Flomax to relax some of the muscles there and the muscle fibers that reside within the prostate, and then by relaxing, take the pressure off the urethra. These drugs work pretty well, but it takes a while, and that was my friend's issue. We also have surgery. We can actually go in and take out the prostate, or most of it. This is something many men actually opt for. We can go in through the urethra and use that to open up the space, or and then the more invasive process is to go into to the abdomen, go around the bladder, and start removing the prostate itself. There are some minimally invasive processes, laser surgery, some ways that we can actually inject steam into the prostate and kill it that way. And so there are a number of things that we can do. There's also some heat techniques. Again, we go in and generate a tremendous amount of heat in a small area of the prostate and literally cook the tissues, and then let the body's immune clearance system take the debris out. These work pretty well. And there's another method using radio waves. There are others as well that can be used. We can also artificially open the urethra with a structure, a stent, just like we'd put in a heart artery, to open up that artery and allow for better blood flow. So we also have interstitial cystitis, which is an inflammatory disorder of the bladder. And the symptoms actually include a lot of pressure, feeling like you have to urinate but can't. You feel that pressure, and then it can be pretty painful to urinate. There's this interstitial cystitis is more common in women than in men. We don't know what the cause is. There's something that happens to create an inflammatory issue. It can be a toxin. It can be actual physical anatomical defects. Can be a lot of things. There can be an autoimmune component to it. Could be hereditary. Here's a little graphic. We won't go through this to a great extent, showing that the normal lining that we see here in the upper left, there's a lot of tissue in there, and as that thins, then we have not as much protection. That outer protective lining protects those tissues. If it's gone, then those tissues can be attacked by a variety of chemicals and other issues. Anything that can cause an inflammation. Inflammations often cause ulceration at the spot, because the tissue is being eroded. It's being killed by that inflammation. So we can also have bleeding. And so one of the other things about IC is that we can see blood in our urine. There isn't anything that actually cures it. You can ameliorate it, and you can cure some of the symptoms. You can even use drugs for this, or you can even use some physical medicine approaches like transcutaneous electrical nerve stimulation to do that, or surgical interventions like bladder dilation. Excess protein in the urine is something that that can indicate several diseases or conditions: kidney disease itself, multiple myeloma, blood pressure increases. We see this also in diabetics because their metabolism is all screwed up. More common, we're seeing ethnic issues here. African Americans and Native Americans will show a higher risk for proteinuria than other populations. This may be something that comes out of long-term dietary differences among those populations. From the sources of protein. There's a lot of speculation about that. Finally, obesity is a major one. Chronic kidney disease is the real nasty guy, known as chronic renal disease as well. There's lots of things that can happen. The kidneys get damaged. Something happens. Maybe drugs. There are drugs that will really wipe out your kidney. Infections can really do a lot of damage. Physical assault on the kidney, accident, trauma to the kidney can also cause this. And what happens is the kidney's blood filtration mechanism starts breaking down. And it starts not being able to do the job of pulling out and putting in the various things that need to go out and in the nephrons. This can be fairly quickly, or it can take time to do this. And since the kidneys are toxin filters, the bladder or the liver and the kidney are really our main ways of getting rid of nasty actors in the body. Since the kidneys are toxin filters, we may see as kidney function begins to fall, and what we see is a buildup of toxic waste. A number of things can happen. It's always interesting to see a whole list of things ending with the word death. If your kidneys don't work, you will die unless something's done about it. What can you do about a kidney that has lost its ability to function? Well, you've got dialysis, which is a nasty, very unpleasant process, and something you need to do 2 to 3 times a week, sometimes more, or kidney transplant. One of those two. We've gotten pretty good at kidney transplant, but still, it's a transplant. It has many other things associated, and you can not even know it for a long time. Other causes. Oops, let's back. Yeah, just a second. I want to get through this one. We can have various diseases that will cause some of these things. Polycystic kidney disease is one. Drugs, and some of the most commonly used drugs, like Tylenol and ibuprofen, are really nasty on kidneys, and aspirin. So actually, Tylenol is worse on the liver. But ibuprofen and aspirin taken in high doses over long periods of time will wipe out kidneys. Okay, let's go ahead and take a break. Let's make it a short one, okay? This particularly unpleasant picture is what a very extreme case of chronic kidney disease can look like. You can imagine these kidneys are not functional. They're also quite swollen. We see two hands there. Generally speaking, they're about the size, your kidney is about the size of a fist. And these two things are,
They're so big as a foot.
they're at least, yeah, at least. So it's a real mess. So there are, you know, it comes on slowly. You can have a lot of symptoms that, other than producing less urine, you might not think are related to your kidney. But what we do is we look at all of that together with looking at the producing less urine, and we want to know what's going on with our kidney function. There are plenty of tests that we can run, and we'll talk about a couple of them later, that tell us something about kidney function. But let's go down to this bottom one, headaches and foggy thinking. And that's probably because of the buildup of the toxins with the kidneys not being able to get rid of them. So we have blood and urine tests. We look at blood urea nitrogen, which is an important component of looking at those. Blood urea nitrogen normally is in the range of 7 to 20 milligrams per deciliter of urine. When it starts rising above that, we start wondering what's going on. Another one is the creatinine test, and the creatinine level is a surrogate measure, what we call a surrogate measure because it's not direct, but the creatinine level tells us about how well the glomerula are working. And normally the creatinine levels are 0.6 to 1.2 in men and a little bit less in women. And it shows how much of kidney function the patient still has. We can do CTs and ultrasounds, and we can take a look and do imaging on the kidneys as well, and look at what they are looking like. We can see on an image something that's swollen like that. That had to be painful to the patient too. And various treatments are available to start treating chronic kidney disease as soon as we know it's occurring. And we know it's occurring because we'll see especially changes in blood urea nitrogen and creatinine clearance time. Diabetics are more prone to chronic kidney disease because the sugar is hard for the kidneys to clear, hard for them to filter out. Hypertension is another problem that can lead to kidney disease. The hypertension puts pressure within the kidneys on the glomerula because, of course, remember from the anatomy talk, we have arteries that feed into the glomerula and they have pressure. And that pressure can actually cause those arteries to change in their elasticity and cause problems with the glomerula. And then weight is often a factor as well. There are various medications. If you look at that list, they're all blood pressure meds. And if you look at the video this week, the RAAS, renin-angiotensin aldosterone system video, you'll see why why these might have an effect on kidneys and have an effect at preventing some kidney damage. But all of these can be used for blood pressure. The RAAS system is intimate in controlling blood pressure. So when it goes bad, if we can lower the blood pressure, we can reduce the possibilities of kidney damage. We have end-stage renal disease, which basically requires dialysis or kidney replacement. A very common urinary tract issue is incontinence. And incontinence can arise from many different sources. And some of them are our own dietary and other habits, medical conditions. There can be physical problems. We can actually see issues that arise from the consumption of alcohol and or too much water, medications, including caffeine, which, even though it's not classed as a drug, fits all of the definitions of a drug. Various neurological diseases that mess up the nerves that control the sphincters. Bladder irritations that cause it to try and void to get rid of what's irritating. And then pregnancies and other things. Age. It's very common to see elderly people having incontinence problems, both urinary and gastrointestinal. And then kidney stones can produce a problem because, of course, the body is trying to get rid of that stone. So there's a graphic here that you can also call up these lectures, but the graphic here talks about a couple of issues related to incontinence. The overflow issue comes from basically a couple of things. One can be urethral blockage, but another could be just not urinating soon enough. It gets to the point where there's so much pressure in your bladder that the sphincter just says, okay, this is it, it's gone. And there's other things, pressure on the bladder from a couple of other systems. Age, this is something that is really important. Aging is not a disease, it's a natural process. It is how the body moves from being robust and active into moving toward death. And as a result, changes occur. Biochemical and physical changes occur. Some of those include the urinary system and the kidney. Kidneys shrink. I didn't know that. Kidneys shrink. We start seeing a decline in that filtration rate. So things like we start seeing elevations in creatinine and BUN. We can have issues with the arteries that are moving into the kidney, and the stiffening, which can be caused by thickening of the arteries on moving into the glomerulus, which we talked about a little while ago too. Uh-oh, what's going on here? Is this not plugged in?
Yeah, the whole table is not, mine's not
Okay.
charging either.
We'll give you that. Plug it in.
Mm-hmm.
All right, well. Is an issue. All of these things change, and we begin to lose kidney function, which of course then builds up toxins and other things that work. Our bladders don't necessarily shrink, but they get to the point where they can't expand as well as they used to. Um, the pressure can change. And so all of these things can influence the urinary system as part of our aging. And of course, we talked about enlarged prostates in men. And women, their urethra begins to shorten as well. Urinary retention is, of course, the other side of the coin of urinary incontinence. Something will cause the ability of the urine to be excreted to be impaired, and that is something that when it's sudden, then it can be a number of different things. Obviously, an obstruction like a kidney stone that's lodged in the urethra. And we can also have stress and other problems. And really, at that point, you should be seeing a doctor, because if it turns chronic, it can turn to a kidney failure. Chronic retention is long-term, and that can be due to many of the same causes. Okay, the causes are I didn't mean to do that. I hate it when I do that. Other forms are related to changes in the continuity and structure of the bladder. Treatments are really, this is where we run into catheters for an acute problem that's a result of some sort of medical issue that we can deal with. We can use a catheter, and there are some for long-term use. We don't like to put in catheters. They're such a source of infection. So what we will do is look at medications to relax the sphincters and allow the urine to flow, or we may have to go to surgery. A long-term indwelling catheter is something that we don't particularly like. This is a picture of what these things can look like. We have balloon catheters and others. What do we do? Well, hey, Amanda.
Yeah. Okay. Sure. Okay. Yeah. I'm sorry.
No, don't apologize. I'm sorry.
Thanks, Amanda. Okay. So this is a good intro to what we're going to do next, which is looking at urinalysis. This is our most common way of detecting these problems. We can find evidence of a variety of different components, and we can use these things with simple dipsticks that use tests that are what we call CLIA-waived. In other words, they do not require a clinical laboratory to do the analysis. They can be done in a doctor's office or a school laboratory like ours. We can also do much longer and more complicated tests of looking at the functioning of the urinary system. We call that urodynamic testing. Maddie? Well, one thing is, as they say here, what we can do is actually see how much fluid we can pump into a bladder through a catheter. So it goes the reverse. Instead of coming out, it goes in. We pump that in until it's full, so we get an idea of the capacity. And then we look at the pressure as the bladder contracts to try and push that fluid out. So that gives us an idea as to the functioning of the bladder, which really is like a balloon. It wants to push things out. So we do that as well. So that's the end of this. I'm going to stop the recording here. If you are looking at this, Ariel, I want you to send me an email with the word Osaka, O-S-A-K-A, in it, so that I know that you've looked at it. So we're going to be going into the lab now to do our urinalyses.